For success in radiology and reading x-rays itself are knowing which views you need, know which films are good ones versus bad ones, and not accepting the inadequate films. Also, you want to read in a methodical pattern, and that's important to make sure you're not missing any known common lesions, but also you want to know the some commonly missed lesions, and then when in doubt, you can phone a friend and call the radiologist if you are struggling with a film or there's any questions that are coming up. So the first film we're going to start with is our standard PA chest x-ray. This stands for posterior to anterior. The PA refers to the direction of the x-ray as it traverses the patient. The x-ray typically is taken with the patient upright in full inspiration, roughly 6 feet away from the film. The second standard film for a chest x-ray is a lateral, which is taken from the patient's left side against the x-ray cassette. This is also taken from roughly 6 feet away. Both of these films are done in the x-ray suite. Comparing AP or anterior to posterior portable films versus a PA chest x-ray is extremely important, because in the emergency department, most likely we're doing AP chest x-rays because our patients tend to be more sick and unstable to go to the x-ray suite. Portable x-ray units tend to be less powerful. These radiographs are taken from shorter distances, therefore the images appear more magnified and less sharp compared to the standard PA films. A comparison of the two films: on the left you have the portable and on the right you have the PA. You obviously see the clarity of the PA film in relation to the AP. These are two different patients, but there is much more clarity as noted on these films. And also, too, something to look at for the portable film is most of the structures appear to be more magnified, which is due to the proximity of the beam, x-ray beam, to the patient. We're going to start reviewing our films, and the suggested pattern I use is the mnemonic A through I. You want to start looking at airway, followed by B, which is bone, C is the cardiac silhouette, D is the diaphragm, E is the edge of the heart, F is the field of lungs, G is the gastric bubble, and H is the hilum of lung, and I is finally instrumentation. First, we'll start with airway. You want to make sure that the airway is patent and midline. Obviously, in a tension pneumothorax, if the airway is deviated away from the affected side, that is extremely concerning. You want to look for the carina, which is where the trachea bifurcates in the right and left main stem. This is important because if a patient is intubated, you want to be roughly 2 centimeters above the carina itself. Next is B or bones. You want to obviously look for any fractures, lytic lesions, any abnormal defects, step-offs, compression fractures. The bones that you're mainly looking at are the clavicles, ribs, thoracic spine, and potentially the humeral heads, depending on the film. In this film here, you obviously see that there is a left clavicle fracture. Next is C, which is cardiac silhouette. You want to look at the size of the cardiac silhouette. A normal cardiac silhouette typically occupies less than half the chest width. In this film presented here, you obviously see that the mediastinum is widened and the cardiac silhouette is much larger than half the width of the chest. This is concerning for an aortic dissection. Next, D is diaphragm. You want to look at both the right and left. The right typically is slightly elevated in comparison to the left, secondary to the liver. You want to make sure you're looking under the diaphragms as well as the costophrenic angles. Typically on the left side, under the left hemidiaphragm, you're going to see the gastric bubble, and under the right, there should be no air, which in this film itself, you actually could see a small strip of air under the right hemidiaphragm, which is concerning for a perforated viscus, which this patient did have. You also want to look at the costophrenic angles to evaluate for pleural effusions, as well as something known as a deep sulcus sign, which would be concerning for a pneumothorax. Roughly, it takes 300 to 500 mLs of fluid to blunt these costophrenic angles. Next is E, which is edge of the heart. You want to check the edges of the heart for any radial passes obscuring the heart border, such as a right middle lobe infiltrate or a left lingular pneumonia. You also want to look at the external soft tissues for any abnormalities and note any lymph nodes or sub-Q emphysema. As in this case, this is a pneumomediastinum, which you can see air tracking in the soft tissue structures of the neck, but then there's air along the left heart border. F is for feel the lungs. You're obviously looking for symmetry, the vascularity, any presence of masses, nodules, infiltrates, fluid, or bronchial cuffing. If there's fluid, blood, mucus, or tumors filling the air sacs, there typically appears to be a radiodense or brighter structure in comparison to less visible interstitial markings. In this film, you're seeing a right middle lobe infiltrate, which obscures the edge of the right heart as well. G is for gastric bubble, which we had talked about briefly in regards to the diaphragm. It sits under the left hemidiaphragm. It's normally a circular structure, and there tends to be some space between the left hemidiaphragm and the gastric bubble itself. H is for hilum. You want to compare, obviously, right versus left. You want to look to evaluate for any increasing size of lymph nodes or masses. On the frontal view, most of the hilar shadows represent the left and right pulmonary arteries. The left pulmonary artery is typically more superior than the right, making the left hilum higher. In a patient with aortic dissection, the left pulmonary artery can be shifted inferiorly, which is concerning. I is for instrumentation. You want to look for any IV tubes, central lines, EKG leads, surgical drains, or prosthesis. In this film, obviously, you're seeing a chest tube in the left chest cavity. Here now we're going to go over a standard PA film, A through I. First you want to look at airway. This airway is midline. It's not shifted. The carina bifurcates normally. B is the bones. Both clavicles appear to be normal without any fractures. You want to run from ribs 1 all the way down to ribs 12. If you could see it, in this case you're probably seeing down to ribs 9 and 10. There are no fractures or step off. The scapula appear to be in normal position. The thoracic spine, as well as the transverse process, appear to line up normally. The cardiac silhouette, this is a normal cardiac silhouette. There's no increased size of the cardiac silhouette. There's no air surrounding it. There's no infiltrative process obscuring it. Next is D in diaphragm. The right hemidiaphragm is slightly elevated compared to the left, which is normal. There's a small amount of fluid in the left costophrenic angle. There's no deep sulcus sign. The gastric bubble lies inferior to the left hemidiaphragm. E is the edge of the heart, which the edge of the heart is not obscured on the right or left. There is no soft tissue abnormalities. There's no air surrounding the heart. F is the field of the lungs. Both the right and the left field lung is normal. You do want to look at the apices as well as the costophrenic angles. A lot of times in small pneumothoraces, you'll see mainly in the apices of the lungs itself. But in this film, which is normal, there are no abnormalities noted. Next would be G, the gastric bubble, which we already talked about under the left hemidiaphragm. H is the hilum. The hilum in this image is normal. There's no distension or abnormalities of the pulmonary arteries coming off of, and there's no hilar lymphadenopathy or masses noted. I is for instrumentation. This patient does not have any instrumentation. The lateral film only adds value, in my opinion. I look for retrocardiac opacities. You can see that the airway is not real well defined, but in this, a lot of times you want to look at bones more so than anything on the lateral. You look at the sternum to evaluate for sternal fractures. You can see the thoracic spine more clearly, and you want to look for compression fractures. In regards to the cardiac silhouette, more so you're looking in the retrocardiac area at the edge of the heart if there's a retrocardiac opacity. The diaphragms here appear to be equal, but the concavity of the diaphragms tends to lead to this within the lateral view. Gastric bubble you could see anteriorly, but does not extend obviously posteriorly on this film. So this is a normal lateral chest X-ray. So in conclusion, chest X-ray success is to follow a systematic approach to make sure you're not missing anything. You want to provide general observations and work your way to specific details. I recommend the A through I method as we talked about in this video. It's always extremely important to compare old films to the new films that you've received or performed today. you want to make sure that you're practicing reviewing films, because as an EM doc, you're going to see 10 to 15, if not more, chest x-rays a day. Always make sure that you contact a radiologist if there's any questions, and realize that studying and reading these films is only going to make you more proficient and become better reading x-rays.